So Bismillah. So the talk today is gonna involve two large areas. I'm gonna present to you social cultural frameworks for understanding health behaviors and outcomes. These are ones that I'm familiar with. There are many others out there, but I think helps us think about this quote unquote Muslim dimension of health. So I'm gonna use Kleinman's model, the cultural construction of clinical reality, and I'm gonna share with you a framework we developed called the Islamic influences on health behaviors. I want to then move to discuss sort of notions of measurement, right? So I had pushed you at the Learning Institute to think about what the Muslim dimension was, but also how you would engage with measuring that. So we're going to talk about that in terms of tools that we have out there for religiosity, for engaging with notions of Muslim identity, and this nebulous area of ontology and ethics, and that will come clearer as we get to that portion of the talk. So the first question, right, that I have for you all is, what do we mean? Now, I mean this particularly in terms of a scholarly research aspect, right? So you all are in some way involved in community projects and community research. So what do we mean when we use the term Muslim? Most sort of basic level, when we use the term Muslim, we think about it as a group of people with some sort of shared characteristics. What you all speaking to were what those shared characteristics might be, right? Could be an identity that's self-identified, or it could be identity, a labeling mechanism where other people say these people are Muslim, right? It could be a set of commitments, be there to certain practices or to certain notions of reality. It could be a group of experiences, right? That they share in a certain experience. They share an experience of participating in certain events or being exposed to certain events, right? And I'll go into more detail about that in a few slides. When we use the term Muslim, it could mean a certain set of values, right? So there are certain values that we say they're Muslim. Like modesty is one that we might say sometimes we color it or we think about it as a Muslim value. What does that mean in research or in measurement? Again, I'll get to in a few moments. Or it could be the shared characteristics of history, or rather beliefs, right? So there's a lot of things here to unpack when we use the term Muslim. And as researchers, I think you have to, and what I was trying to make you think about was, what is that, right? So not just what your population of study is, but what is that label of Muslim that you want to tease out and understand when you're doing your work, right? There's something there that's shared. What is that? In terms of defining your problem, in terms of trying to rectify the problem, in terms of health broadly. So when I use the term Muslim, when we use the term Muslim, we're applying a label that suggests some sort of lumping activity. It signifies something that's uniquely shared, makes this group the same, right? Or people within this group the same, or within group similarity, but also an external group dissimilarity. Right? It makes this group similar in certain ways in terms of their health behaviors or their health outcomes or their health beliefs, but different from another group, right? And so it's a dual-edged sword. You're trying to lump people together, but then you're also trying to disaggregate them from another group or a general population, so to speak. And then as a researcher, you have to bear both in mind, actually. It plays a role in your analytic plan. It plays a role in how you then describe what you find, right? Because and let's take it at a more general example, what is the same when you're writing up your results and you say, well, we found this characteristic amongst Muslims was same as XYZ population, right? Christians or Jewish people, but we found this unique to the Muslim population. So it sets up a way for you to think about what's unique for interventions. It also sets up what's similar to other groups that we should think about strategically getting resources for them, right? That they also suffer from certain types of discrimination or certain types of poor health outcomes. Therefore, there are a target group for interventions. Okay, now in terms of the background, before I get into these models, right? Traditionally, religion and health research focused on this impact of generalized religiosity, right? There wasn't given much attention given to specific religious traditions. Rather, the idea was, well, if you hold a religious system, perhaps there's some sort of practices that you enjoy in some community, social structure benefits that you have that others don't, and this has a relationship to health outcomes. And so an example would be, religiosity and health, and blood pressure. People who aggregate around religious structures, those church-going people or people who go to mosque, go to temple, right? They have a different blood pressure characteristic profile than those who don't, right? So there's a general religiosity sort of structure. In terms of health disparities work, generally, you all know, and I present this again at the Learning Institute, that health disparities research in the United States, at least, is aggregated across the lines of race, ethnicity, and socioeconomic status, predominantly. This is by law. This is how they mark quality, right? This is how they measure quality of healthcare delivery. But that's particularly the United States, right? If there were other countries, they have different ways of thinking about healthcare disparities. And the assumption underlying all this is that relevant health sort of related beliefs, experiences, and cultures aggregate by these categories, right? That people of African American background share in social experiences that are related to their health outcomes in a certain way, right? That are similar to just that group compared to another group, to maybe Latinos or to Mormons. Similarly, people of the same ethnicity, right? Hispanics and Latinos, they share in sort of food habits, for example, that convey certain health risks or benefits to that group itself, right? And therefore, we have to think about how to uniquely help them think about their health or socioeconomic status, right? People who are indigent, whether they're white or black, but they live in food deserts, have the same health risks, have a similar health risk profile because of their relationship to being able to get healthy foods. But that's how it works in the United States, right? Religion, as I mentioned there at the Learning Institute, is not captured by healthcare disparities paradigms. However, right, in terms of where we're going, right, or you all, I hope, are going to go, is that there is some relationship between all these things and religion, right? So religiosity does act independently on health when you compare people from the same ethnic but different background, right, but different religious groups, right? So African Americans who are Muslim versus African Americans or Christians, right? There is some independent religiosity effect here in certain health outcomes. We know that from research. Similarly, instead of general religiosity, particularized religiosity, like so, for example, fatalism, right, acts differently amongst groups and of different religions. So it's not the same phenomenon within a Christian group, within a Muslim group. And this leads to a measurement issue at times. Again, forecasting ahead what I'm going to present in a few slides down the road. All right. So that's the background. And so when I'm pushing you all to think about Muslim dimensions of health, this is the background of what you're dealing with, where people don't think about disparities in terms of religion. People don't think about, or generally haven't previously thought about, particularized religiosity. And so our challenge as Muslim health researchers, so to speak, is to actually convey how this is different, right? Why is this group different? Why is this group particular? And in your measurement, you have to also do that. Okay, so this other background stuff you also know, right? We know that Muslims, and this is the pushback some of you were giving me at Learning Institute, well, Muslims are diverse, right? They're racially, ethnically, and socioeconomically diverse, right? So why should we lump them? And I had responded to you at the Learning Institute that there is a strategy behind that. That not only is it theoretically or conceptually okay to do so, but there's also a strategic usage of that, right? That makes you have more significance potentially when you talk about your project being translatable to other groups of Muslims, or that your work is of has generalizable characteristics. Your findings have generalizable validity, right, across groups. So while each subgroup within the Muslim community has its own social and cultural history, there is, and you all know this, a shared religious worldview that does shape that members, meaning the Muslim community's health behaviors and their healthcare interactions, and that they share in the social experiences that impact health. So I've highlighted behaviors, interactions, and social experiences because the model I'm going to share with you in a few slides deals with these three sort of domains: health-related behaviors, what they do to move from illness to health, healthcare interactions, how they perceive the care they receive within the healthcare system, and their social experiences, what happens outside of the healthcare system, so to speak, right, that impacts their health. Our promise, the promise of this project, the promise of your work, is that it will add on to this group of studies that have shown that Muslim religiosity can both hinder and promote the health of American Muslims. We know that, right? That people of certain sort of religious belief structures can think that those belief structures provide an obstacle to health, Others believe that some of those can promote health and can make them more healthy. So when you do your research, and I would like you to think about where religion is coming in. Is it a barrier? Is it a facilitator to health? And also in your modality of developing your projects, I would argue that the diversity of the community allows us at times to isolate how shared religion independently works across racial, ethnic, and socioeconomic lines, right? So doing mosque-based projects, mosque-based research, you know that you have a diverse population coming through that door, but they share in that notion that they have a relationship to Islam in a certain way. And that shared aspect of their identity is one that can be leveraged and mobilized to promote health. Okay, so that was the background. Let's talk about Kleinman's cultural construction of clinical reality. I think some of you probably know about Arthur Kleinman. He's at Harvard, a prominent psychiatrist and anthropologist. He's done a lot of work, and I think his model of what healthcare seeking, or his model helps us think about healthcare seeking behaviors. So Kleinman's structural domains of healthcare and society, how he thinks about health and illness, right? Illness, he argues, is handled in different domains. Each one of these domains has, right? So when someone moves from a state of perceived ill health and wants to get to a state of wellness, right? They interact with these different domains. And each one of these domains has its own explanatory system, social rules of interaction, and has their own sort of quote unquote institutions that provide that intervention to move from illness to wellness, right? And the cultural construction of clinical reality really means that there are various explanatory models that are used by patients and providers when they're engaging with illness and with healthcare, right? That there's a cultural value that the healthcare system has itself, physicians, right? Allopathic healthcare providers versus homeopathic providers, or patients from different cultural backgrounds come with a different explanatory mechanism to understand why they're sick and what those symptoms mean, right? So the etiology and the experience of illness is culturally constructed. And he argues that there are only three domains, and I think that works. There are only three domains of how you engage from moving to illness to wellness in the larger sort of social reality. And what are these? There are three, right? The allopathic, so allopathic, family or social networks, and then non-professional healers and alternate treatments. So you could sort of say the contemporary conventional healthcare system as the allopathic, the social health system, right? This is family, community, and then the folk, right? The non-professional healers or alternate treatments. And he uses those terms interchangeably at times. So with that said,
these two things together, right? So let me give you one. So imagine that you are a person who is feeling a stomach ache, right? And you're feeling a stomach ache, and then you say, why? What should I do? I'm sort of suffering from a stomach ache. And then you say, okay, you think, well, last night I went out and I had a cheeseburger at McDonald's that wasn't zabiha. And because of that, Allah is now giving me a taste of, recompense for eating a non-zabiha halal cheeseburger. So you decide, I'm going to not do anything. You do salah and you're done, and then you feel better. So that's your engagement with the folk notion of what's the etiology of a disease, because of some failing I have, a spiritual failing. What's the ontology of cure? Well, then if the disease is coming about because I did something wrong vis-a-vis my responsibility to myself vis-a-vis God, and I'm going to then seek a cure that's just dependent on God, right? You move forward, and that actually doesn't change anything. And you're still, now you had a stomach ache, now you have diarrhea. And then you go to your spouse and you say, well, what else should I do? Your spouse says, I have some Imodium in the the bathroom cabinet. Why don't you take some Imodium? So you take the Imodium, right, hoping that you are going to be, moved from illness to wellness through that modality. So what has that person done? They've engaged with the popular, right? They've talk to their spouse who is not a physician, but in the popular domain, there is Imodium. You can get it over the counter from a pharmacy. And they took that medicine with the hopes of moving from some measure of illness to a measure of wellness. Okay, that Imodium helps with the stopping the diarrhea, but now that person's vomiting. So you say, okay, you know what? I'm going to make an appointment with my doctor tomorrow. And so then that person goes to the doctor tomorrow and has now engaged within the allopathic system. And the doctor says, why didn't you come to me yesterday? Why did you come today? You're dehydrated. You had diarrhea and you've been vomiting all night. And the person says, well, I thought this was because I did something wrong spiritually. I want to take care of it that way first. Right? So see, then the narrative is, well, how would you test that out? Well, if you were going to do studies on religiosity and health behavior, perhaps those with a higher level of reliance on God, there are metrics like that, or positive religious coping, for example, or higher levels of religiosity might present later than sooner when they were struck with some illness. So that narrative should give you a sense of how you think about these three domains. And Kleinman argues there are only these three domains of moving from illness to wellness within a given society. Okay, that's just a slide just depicting that. So, I think now moving that from that sort of schematic of framing of health behaviors, thinking about research in general, religion can contribute this construction of reality by the narrative I've shared with you. It's the way that people of a particular religious tradition, in our case, the Muslim tradition, would perceive, label, and evaluate their illnesses. That has to do with their health beliefs and the behaviors that they take in trying to move from illness to wellness. And that there might be some discordant views of clinical reality between the purveyor of that healthcare package, be it a allopathic physician or a folk healer, between the patient and the provider. And that can lead to then healthcare disparities or health disparities in general and poor outcomes when there's discordance between these different versions of clinical reality. Okay, so here's sort of my advice for some of you, and bearing in mind what projects you came in or applied to the cohort with. So I do think that using Kleinman's three domains can help you elicit narratives of moving from illness to health, like the one I just shared with you. And I do think that is one area of research that is particularly promising for us as we think about why Muslims do certain things or which Muslims do certain types of things. So for example, how Muslim youth deal with the complications of alcoholism. Do they go to the folk healers? Do they go to imams, so to speak? Do they go to counselors? Do they interact with the healthcare system? How do they do that? I think that sort of work is particularly valuable. I also think that using or developing your own measurement tools within each domain is important to understand the interaction between that realm, or actually the different actors within that realm. So using the same example, is religiosity protective against alcoholism? Yes or no? What types of religiosity? There are many different ones. Does a strong religious identity prevent help seeking in certain behaviors? So for cancer, or for or for alcoholism, or for something else, for mental health, right? And using the same example of alcoholism, right? Do imams actually provide a source of counsel or prescribe ruqya for alcoholism? This is purely within the domain of what Kleinman would say would be folk healers, right? How do the folk healers work with this population? That's another area of promising research. So I think that if you use Kleinman's sort of framework, it can help you elicit narratives and see the entire scope of how Muslims are engaging with dealing with their own quote unquote illnesses, but also how they're moving from that state of illness to wellness. Okay, so I'm gonna now transition a bit, talking about health through the Muslim lens, and share with you some data and some research studies, right? So we know that Muslims in generally have a God-centered view of healing, that there are different actors within that, right? Doctors, imams, family, and community are different resources or sources of healing. This all aligns with Kleinman's model of the three domains. We know that Muslims use different types of means to get from illness to wellness, and particularly there are some that are religiously based, right? So this could be worship or herbs or text-based practices that produce healing. And we know that Muslims in general, from population-based work, that they believe that health and illness, right, are controlled by God's decree, that humans play a secondary but complementary role. So this is for some Muslims at least, is a significant overarching framework for their thinking about health or illness. We know that the construction of health for Muslim populations, and you all know this as well, so I'm going to just buzz through these slides, that there are different dimensions, right? There's spiritual, social, and physical health, and that for some people, spiritual failings might lead to, or they might interpret that spiritual failings lead to their physical symptoms. And we know that disease is constructed through a cultural or religious framework, right? Some might see pregnancy as a blessing, therefore that impacts the way that they engage with contraceptive practices, or that cancer, for example, might be related to decree or fate, and therefore prevention is seen differently. For example, in the Somali community, therefore there's not a priority so much on screening for cancer. But this is all Muslim. These are all Muslim dimensions, right? We might have a view of whether this is right or wrong, but we know that these factors interact in Muslim health behaviors. So I'm going to skip this question that I had for you all about how Kleinman's ideas and domains can relate to that. But the point is that we should at the Learning Institute, but I want to reintroduce you to it, is this of how health practices and how Muslim behaviors can lead to health inequities. So I gave you an example last time, but I'll just work through an example, right? So that there are health practices within the tradition, say, for example, fasting, that might lead to ethical or cultural challenges within a clinical setting, right? So do I break my fast to get this medicine, or do I not? That might lead to a clinical challenge. And people, if the healthcare system sort of is able to successfully navigate that challenge, right, that will impact the healthcare seeking behavior of those patients. If they're not, or successfully navigate that, patients might perceive that as discrimination or lack of cultural accommodation. That would negatively affect their patterns of healthcare seeking down the road. And then that would produce health inequities, right? So that's this middle pathway. The other notion here I just present to you about interpretation of health or lack of health based on Islamic theology. One might perceive that their malady is related to some sort of spiritual failing. That obviously then also has effects upon the patterns of healthcare seeking. That might lead to health inequities, not healthcare inequities, but health inequities. There might be differences outside, not related to the healthcare system, for patients of a certain background, or positive things, right? On the other hand. Lastly, what connects the Muslim community at large in the United States and in other diaspora communities is that being a Muslim is in of itself a risk factor for adverse social experiences, right? Discrimination, abuse, bias, microaggressions. This all impacts Muslims as a health-related exposure. I think we have some good work out there, but it still needs much more detailed study about how being a Muslim impacts your health in the context of our current social, political, and cultural climate. All right, so or their health practices. We want to provide evidence for guidelines, right? So when we talk about cultural competency guidelines, we want to provide evidence for that, or for healthcare policies. And really, a lot of us, right, in this EMARCH cohort, work in advocacy roles for the Muslim community. So we want to provide data that is sound, that can make pushes for advocacy for certain types of resource allocation from society towards Muslim health. You know this slide, I shared with you that there's very little out there about Muslim healthcare disparities. When we did this work, now this is almost 10 years ago, we had found that there was only 171 studies right out there, and only 19 talked about Islam as an important determinant of health. And I think that's an inappropriate caricature of how Muslims writ large engage with healthcare. That Islamic identity or their ontological frameworks do impact their health-seeking behavior. So I want us together right? And your projects to push the fold and say, no, this is if we well, at best what we have presently are local projects. All right. So moving forward to talk about each one of these domains. And so I've presented the hard conceptual work. Now we're going to kind of take it a little bit easy and talk a little bit about each one of these sort of domains and how we would think about measurement within them. So the professional domain, I suggested that one way to understand the Muslim dimension here, this is just one example, is to measure religiosity and health behavior. So how do we measure religiosity, right? If you want to measure the effects of religiosity within the professional domain, there are many different measures. Here are some. So religion-related measures that I've used and others have used, and I'm sure you guys have used, right? Durrell, the Duke University Religion Index is a good one. We've adapted it for Muslim populations, but it measures religious practices, right? Their relationship people have to organizational and non-organizational religious activity. So attendance to mosque, for example, prayer, silent prayer, reading the Quran, which is non-organizational. These are things that are captured by Durrell. The psychological measure of Islamic religiousness is not a practice-based measure, but it has to do with more a psychological, obviously, measure of how people engage or understand their faith. The ones that I think that are best within this PMIR are those that relate to coping mechanisms, positive coping mechanisms or negative, right? So they have the punishing Allah reprisal what's it called, subscale, which measures how people think that their illnesses are because of God punishing them, or there's a positive religious coping measure, then this is their reliance on God for cure type subscale. You guys can correct me if I'm wrong, but anyway, those are the ones that I've used. I think those are good ones, and I've actually adapted them, so I can show you the adapted ones if you'd like, if you want to use those. These are sort of, now you went from organizational practices to psychological measures of religiousness. Now there are particular measures of religiousness that have to do with specific ideas, or right, like modesty or fatalism. These are correlated with religiosity, but not fully overlapping. So I have a couple, again, I'll share with you that I've used and I've developed and validated with the Muslim populations, but you might have others. And there might be others out there that talk about not modesty or fatalism, but other aspects of religiosity that can be correlated and measured in terms of health behaviors. And you all know the different methods for measuring health behaviors, surveys, or just one one method that we talked about at the Learning Institute. So the slides you'll get again, but here's, for example, the Duke 10-item measure, or these are 5 of the 10 items. I'm sorry, there are 5 items there. These are the original measures items. Some we've adapted, I can share with you. This is, for example, the 5 subsets that they have, or some of the 5 subsets they have for the psychological measure of Islamic religiousness. Here's our modesty measure. And there's a religious health fatalism measure that was used, the RHFQ, that was developed from the African American population. We adapted it for the Muslim population and tested it. And so this is another subscale. So these will all be in your slide set, but just giving you a sense of different types of measurement tools. Now, within the professional domain, I wanted to not leave that domain without sharing with you, and Amal knows this work as well, that we know that there are some areas within the healthcare system that Muslims have found wanting, right? And American Muslims ask most about in terms of their religious accommodation around gender concordant care, halal food, and access to neutral prayer spaces. This is within the hospital system itself, and that lack of these accommodations can be interpreted by the community or different members of the community as discrimination and do impact the healthcare seeking decision. So if you're going to do, if your project is in some way related to the professional domain, interaction with the professional domain, these lack and does that impact the way in which the Muslim community engages with the healthcare system. Okay, this is just a slide about different sort of national health surveys, which don't have religiosity in them, but you might be able to get some demographic profiles of Muslims, or at least use as comparators to. So, for example, if you're going to do a study on food and the dietary habits, instead of creating your own items, use items that are similar to the CSFII, and that way you can compare your data set to theirs, or how Muslims compare compared to the general population. Okay, the second domain, according to Kleiman, is the popular domain, right? The community, the family, the social culture, the social relationships one has. And I suggested for you that in this domain, it's particularly important and valuable for us to think about Muslim health decision making. We know that most decisions regarding when to seek aid, right, for a malady occur in this domain. And that contrary to popular belief, we know that healthcare system only contributes to about 10 to maybe 15% of one's wellness, one's health outcomes, that the popular domain is where most of it is at. Most of your health is associated to the way in which you relate to the popular domain of healthcare. So I'm going to skip this question as well, but we talked about how this might relate to your populations, right? And so I think that you should pay significant attention to this popular domain. Most of you have been asked or have came into this EMARCH cohort thinking about mosque-based work. So this is mosque-based work in a sense, right? This is a popular domain. There might be folk, quote unquote, healers within the mosque, which you might study, but this is where your projects might be situated. So here I think that you should think about the Muslim dimension about how certain behaviors are motivated or others restricted in the popular domain, right? So for example, breastfeeding is in the popular domain. It has health benefits. How is that related? How is that related to the Muslim dimension? Well, some people from our own work, we know that they talk about the verse in the Quran about rearing your children for up to 2 years, and their breastfeeding is seen as a positive thing, a Quranic imperative, so to speak, and therefore this is a method of conveying health benefits to their children. We know about obviously many verses, the verse in the Quran prohibiting, but the main hadith prohibiting alcohol consumption. That's also in the popular domain, how it conveys health. A restricted abortion, again here, when can we abort, not abort, right? This is a religious guideline. That is also in the popular domain, right? If people are not seeking the abortion, which means they're not going to the healthcare system, but they're dealing with and having children that might have severe developmental delays, this is again a choice that's made to stay within the popular domain. So how does social support for those developmentally delayed children occur? Again, the ethical legal framework here governs the acceptance of treatment and manner of receipt. So now this can impact that relationship between moving from the popular domain to the professional domain, right? In the way, for example, I have 2 examples here about gender concordance and porcine-based vaccines. So the ethical legal framework might suggest people who have views around whether porcine vaccines should be taken or not taken, might keep them within the popular domain so they don't get them, or they might go to the professional domain because they have a fatwa that says you can. This other large thing, many of you talked about Learning Institute, and in your essays was about discrimination and Islamophobia. Again, this socially marginalized identity occurs within the popular domain, right? People have increased psychological stress and low levels of happiness because of the abuse and discrimination they face post 9/11 world. You know, there's upsurge in hate crimes and negative stereotypes. This again contributes to how people engage with the professional healthcare system or whether they remain within the popular domain of healthcare seeking. Okay. This idea of discrimination sort of bridges the popular and the professional because it could lead to maladaptive behaviors that convey risk for further health deterioration, which might force individuals to be engaging with the professional healthcare system, right? So smoking or avoiding healthcare, avoiding healthcare is one thing, smoking is another, and smoking conveys risks, or stress-related illnesses, or poor mental health. Some of it might be resolved within the popular domain, some of it might have to go to the professional domain. And if you have delayed healthcare seeking at baseline, this can lead to worse outcomes in the healthcare system, right? So it's a spectrum bias that people. So, for example, let me just speak clearly for a moment. We know that certain pockets of the Muslim community have higher than the general population. They have higher rates of a higher risk for psychiatric illnesses. So at baseline, they have a higher risk. If that risk is if that community is also facing social pressure where they don't want to go to the healthcare system, then that risk is compounded. When they enter the healthcare system, then you say, okay, well, if I'm studying some sort of treatment for depression, but this group is a spectrum bias. This group already had a higher risk, had higher disease sort of profiles, and when you test their treatment effect versus general population, you find that your treatment is less effective. The reason is because they had a higher baseline risk, right? They were worse populations with worse measures. So there are several different measures of discrimination. Again, we've used the discrimination in medical settings scale, and we've adapted that a little bit for religion-related discrimination. But there are many of these out there. I do think that you can use any of these to study, and there's some that are Muslim-based as well, how discrimination impacts health behaviors and how that relates to healthcare seeking. Okay, so the last domain is about, as I mentioned, etiology of disease and ontology of cure. We talked a little bit about this, by these characters of Muslim health at the Learning Institute, right? That there's a lot of work on Muslim mental health. An external evaluator or observer might say, well, does that mean that Muslims have a lot of mental health problems, more so than other communities, right? There are these other institutes for, healing by the Quran and Sunnah. So does that mean there's some problem with the allopathic mental health care that Muslims have to go to these folk domains of healing, right? That how we conduct research, there are external observers, funders, or policymakers that look at what we're doing and can generate caricatures, and we have to bear that in mind, that they are an audience for the work that we're doing. I spoke about this already, that rather than seeking healthcare within the professional domain, Muslims might use, and emphasize spiritual causes of illness and seek to address them within the folk domain. So this is that last domain. So we know for example, illness as spiritual failings might lead people to go seek ruqya, for example, from imams, or they might use traditional measures such as cupping. That some people just say, I will use religious rituals, I'll pray more, I'll fast more. And then this whole domain of psychiatric illnesses, there is this thing of jinn possession, but aside from that, there are other aspects of how people think about mental health illnesses and go first to sort of spiritual counseling as opposed to conventional psychiatric medications. All right, so we're near the end here. The summary I have for you when you're talking about the Muslim dimension of health is that religion, despite it having a potential to influence health, is not recognized as a factor in healthcare decision making on a national scale. And even within this population, that has been not well studied. Those relationships are not robust. However, I would argue that religion acts alongside, not within other sort of healthcare indicators of race, ethnicity, and socioeconomic status. That religion acts alongside them, within, and not necessarily within them. So we can aggregate people across race, ethnicity, and socioeconomic status, and see their shared religion framework working. Religiosity can impact health negatively at times, but it also can facilitate positive health behaviors and outcomes. And figuring out what aspects of religiosity are positive, which are negative, and whether that's something that's good or objectionable is something that we can do through health research. But you're not going to study, right? You're not going to study religion-associated health disparities without thinking about them in advance, within your hypotheses for your research, within the way that you're setting up your projects. And that's why I was talking a lot about the Muslim dimension of